inquiries and tribunals, I think they're very difficult situations, not only for you, but for the family members and for the patient. It's incredibly awkward because you're essentially telling someone why someone needs to stay in hospital, and you feel like you're rattling off a whole list of impairments, and it can be quite difficult.
I mean, in terms of the tribunal, I don't know how much my view fits with a consensus, but I have a very sort of straightforward understanding as to how to approach a tribunal. I think the first step should always be, is the tribunal necessary? So I think when you get a list of your patients that are due to see a tribunal, I think it's worthwhile reviewing them and the file and discussing with the multidisciplinary team is to see whether, one, do they have to remain in hospital? Or two, is voluntary status more appropriate?
Tribunals can be a very daunting thing, especially people who haven't had experience with it before. What I found that was really quite helpful is to try and attend them, even if you're not in a speaking role, with a registrar or someone senior that may have been doing it for a bit longer, just to get a handle of how it's sort of run.
Ideally, you should never go into a tribunal, at least the first one, by yourself. Observe your registrar present a couple of tribunals and you'll get the hang of it. You may have to do tribunal reports. So the definition of mental illness for the tribunal is different as compared to a definition of a mental illness by a doctor. So I think that's kind of what we view as mental illness may not be viewed as mental illness by the tribunal and vice versa. So the tribunal are basically just symptom oriented. It doesn't bother them what the diagnosis is. It's just what the symptoms are. You don't have to do an extensive tribunal report. The tribunal doesn't need to know how many cigarettes they're smoking or what sort of substances they use. It's just basically a highlight of, look, this is the background of this patient. Very briefly, they live with whoever, they live by themselves. They've got this history of illness for a long time. They've got this history of being admitted into hospital for a long time. This time what happened was they forgot to take their medications for a week. Someone noticed that they were unwell. They came in, this is how they were, this is what we've done, and they still are unwell because of this. That's all they need to know, is what they're unwell in. And they're very much risk-oriented, the tribunal. So all you have to kind of express to them is, look, this is what they've done when they're unwell to put themselves or their reputation or their house or their finances or relationships with others, anything you can think of, at risk. Or you can say, and look, it's too early to discharge them. If we discharge them, they might relapse, and again, this is what the risk is involved. The only two things the tribunal look at is symptoms of mental illness and what's the risk.
Always make sure that you know when your patient's orders expire, especially if they're due for an inquiry or a review or a CTO, and that they're on the list. And the most important thing is actually making sure the calls to family are made before the day of the tribunal, ideally 2 days before, and that the patient is aware and they've gotten their CTO paperwork handed and you filled out the form saying they got their CTO paperwork handed. The other thing is all the paperwork's due apparently 48 hours before, but usually by midday the day before it actually has to be in. So you can always ask the reg. Most of them have a template if you want to help with the letters, and that's always really good. But generally just make sure you have an awareness of when things expire and make sure the calls are made.
So when you're writing your tribunal letter or your inquiry letter, it's always good to keep it brief and know two facets. So what are the symptoms of mental illness that this patient is meeting? So delusions, hallucinations, disorder of thought form, and irrational behaviour that might suggest the presence of either of those. And then you have to address the risk. You can have a mental illness and not pose a risk. However, if you have symptoms of mental illness that put you at risk of harm or risk of harm to others or risk of deterioration without treatment, that's why they need to be kept in hospital as the least restrictive form of care. So knowing those two facets inside and out, that's all the inquiry cares about. It's a legal proceeding. It's not medical. They don't need to know a diagnosis. They need to know symptoms and how that correlates with risk.
Really, there's only a few things that I think about. The first one is, what are the symptoms that we're observing? And how does that fit with the Mental Health Act? So the Mental Health Act, in terms of mentally ill definition, is really quite specific. So you're talking about the severe disturbance of mood, disturbance to speech or thought form, delusions, hallucinations, or evidence of any of the above. Then what you have to think about is, what evidence do you have that those symptoms are present? Unfortunately, what can happen is sometimes people will observe something and then communicate it to someone else, and then communicate it to someone else. And all of a sudden, the behaviour has become inflated. And you want to avoid that, because it's not fair to the person, and it also influences their care. So that's when you need to, when you're thinking about, okay, these are the symptoms that we are observing. What is the evidence for them? Are they in the nursing notes? Are they reported by family? Have you observed them directly? Are they part of the mental state exam? So you have to, I would also put that in there.
You don't have to release the report to the patient, and sometimes patient can ask. You have the right to refuse, and you can say that this is not the appropriate forum for you to go through that report. Your legal aid lawyer has already gone through that with you, or your lawyer has gone through that with you.
In theory, you won't be in a tribunal alone. But have a read over, I guess, there's a pretty simple formula for what an involuntary treatment order means legally and what criteria you have to meet. So you just need to say they have a mental illness, what symptoms reflect that under the Act. So do they have delusions, hallucinations, whatever? And then go on to say, why is hospital the least restrictive form of care at this time? So maybe they won't take medications if they're out, maybe the risks are too high, say what the risks are, and then recommend your treatment order length. And if they want more, they'll just ask for more, but generally go light. Use clinical terms for things that are insulting or that the patient might disagree with, like going into specific delusions might be quite distressing to them, or saying that they, are experiencing things that aren't real might upset them, and they might be quite insulted by that. But use general terms when you're saying something complimentary, and don't be afraid to compliment the patient on how much they've improved or what they're doing really well at, because that will make the whole thing easier. Also, make sure you talk to the patient before you go in, and just let them know what's going to be happening and that you're all on the same side, because if you don't do that, they can get quite offended, and it can be a bit difficult for the therapeutic relationship.
Inquiries and tribunals, I think they're very difficult situations, not only for you, but for the family members and for the patient. It's incredibly awkward because you're essentially telling someone why someone needs to stay in hospital, and you feel like you're rattling off a whole list of impairments, and it can be quite difficult. So I think what's good to keep in mind is a few things. Educating the patient and the family first about, look, this is what the tribunal is like, this is what the inquiry is like, this is who's going to be there, this is what we say, and making sure that they have their information about the Mental Health Act and the Statement of Rights, which is really important, and also being clear about what it is that we're keeping the patient in hospital for, which will also help in clarifying to the magistrate or the tribunal members exactly how you're meeting the criteria for the Mental Health Act. And so I think that's your best port of call to approach these tribunals and inquiries.
Then after that, you have to think about, because the next part of the legislation that needs to be addressed is, what are the risks? And I think that has to be very clearly defined and very clearly documented. there can't be any maybe this, maybe that. It's either there or it's not. And you have to have some idea as to what you think the risk of that eventuality occurring is.
Different members of the panel and different people that do sort of run it can have a different approach, so each tribunal might be a little bit different. But the overarching theme of a tribunal is that it's designed to be non-confrontational, or that's the intent behind it anyway. But oftentimes that's not the case, especially with some of the legal aids can sometimes put a lot of pressure on the treating team to justify themselves, and they should rightfully do that.
And usually the final step for me is you have to ask yourself the question, can't these risks and symptoms be treated outside of hospital? And if the answer to that is yes, well then discharge planning should occur.
What can really help it go smoothly and to avoid any form of being stuck in a corner, not being able to answer something really well, is to make sure you do a good report. So the elements of a good report would be make sure you've outlined very well what the patient's presenting complaint was, including any factors in that presenting complaint that would make this patient a particular sort of high risk if they were to be discharged. What can also be quite helpful is the past psychiatric history, previous admissions, length of admission, which can justify how long you're applying for in that order of the tribunal, and of course their progress on the ward. And sometimes the nursing staff can be of quite a lot of assistance during the tribunal process itself, to be able to give sort of additional information of what the patient's sort of been like, to justify why the patient needs to remain in hospital.
Sometimes magistrate asks if you want to add anything to the report, and usually my answer is no. I think that's quick and easy. If they say to speak to your report, do not read out the report. All right? Because I think when sometimes I've seen a couple of JMOs, they don't know what to do, so they've read out the report, and it kind of annoys everyone because everyone's read the report, and it's just basically you can refer back to your report if you don't want to reveal sensitive information that you think might hurt the patient. You can say, as outlined in the report, I'm worried about these, or Mr. X was really unwell, and the symptoms were outlined in the report. You can always refer back to the report.
It's also really important to be aware of the fact that, generally it's not considered a particularly pleasant experience. So it's important to tell your client that it's happening, and it's also probably a good idea to tell the client, give them an understanding of what you're going to say, because they can see your report and they will be there when you give your account. So I don't think it's fair to give people warning as to what you're going to say and what your recommendations to the tribunal are going to be.
The final thing I would say in terms of the report would be the recommendations that you would give, and also highlighting of the specific risks. So you can mention it in the presenting complaint, but at the end it's always a good idea to have like a bit of a summary statement, something along the lines of this patient is presenting with signs and symptoms indicative of such and such condition, evidenced by either major disturbance of mood or evidence of disordered thought form. And once you have that sort of statement, you can justify whatever risks are appropriate for the patient, be it self-harm, harm to others, risk to reputation, just so you have it outlined and you can refer to that in your report.
So that's my sort of straightforward approach to it. And I think if you stick to those sorts of principles, then the tribunal process should go quite smoothly.
In terms of the tribunal process itself, like I said, it can be a little bit variable depending on the members on the panel, but as long as you can address those questions and make sure you have a pretty ironclad report, they tend to go quite smoothly.